When it comes to the embolization procedure itself, one of the first questions people ask is about the materials being used. What exactly goes into someone's body? Initially, we perform this procedure using something called particles. These are very small, calibrated microspheres, typically made of a gelatin-like substance. They come in various sizes, ranging from about 100 microns up to 800 microns, though we usually use the smaller sizes, around 100 to 300 microns. Since these particles are not visible under X-ray, we mix them with a dye, usually standard X-ray contrast, before injecting them into the prostate artery to block it. Over the last 3 to 4 years, I've been working on improving this technique. Interestingly, one of the things we've been exploring, and this might sound surprising, is performing the procedure without using particles at all. There are some technical reasons we believe the particles may not be as effective, so we've been experimenting with using a medical-grade adhesive called cyanoacrylate, essentially a medical version of crazy glue. This glue travels into the targeted blood vessels and permanently seals them. We think this approach may lead to better outcomes because, as some studies show, about 20% of men experience recurrent symptoms within 5 years of a successful procedure. This recurrence often occurs because the previously blocked blood vessels reopen. You can imagine inserting tiny balls into the vessel that clog it initially, but over time, the body may absorb or move those particles out, reopening the flow. With a glue-like substance, however, the vessel is permanently damaged and unable to regrow, which appears to offer more durable results. There are also a few technical innovations worth mentioning, such as accessing through the wrist artery and using different materials. These advancements can improve both patient comfort and outcomes. We now use highly advanced imaging equipment, allowing us to perform what is essentially a CAT scan in the operating room. This means that if we're uncertain about an artery's pathway, we can instantly obtain a 3D image that shows exactly where we're injecting the dye, revealing the full prostate anatomy for precise treatment. Every patient's anatomy is different, so being able to visualize these vessels accurately is critical. New imaging systems also reduce radiation exposure significantly, making the risk of high-dose radiation extremely low. To put this into perspective, the typical radiation dose during this procedure is between 12 and 17 millisieverts, roughly equivalent to or even less than what you'd receive during a standard CAT scan, and comparable to the exposure from a transatlantic flight. However, this is a technically demanding procedure that requires a high level of expertise. While some physicians may only perform it occasionally, it's important for patients to seek out interventional radiologists who specialize in it and do it regularly. Experience makes a major difference in safety, efficiency, and results. When it comes to patient referrals, I receive cases from urologists, primary care doctors, and even patients who find me through online research. I personally evaluate every patient beforehand, conducting a full assessment that includes CAT scans, uroflow tests to measure urinary stream, ultrasounds to assess residual urine volume, and blood tests including PSA levels. The entire evaluation is non-invasive. No cystoscopy is required in most cases. This comprehensive approach is essential because urinary symptoms can arise from various causes, not just BPH. For instance, symptoms like weak flow, dribbling, frequent urination, or nocturia may also be linked to bladder or neurological conditions. That's why a proper workup is critical. Skipping it increases the risk of missing an underlying problem and achieving poor results. If I determine that a patient isn't a good candidate, I'll say so directly and recommend other options. There are many treatment paths for BPH, and while prostate artery embolization is an excellent one, I even plan to undergo it myself soon, it's not suitable for everyone. Regarding success rates, outcomes depend on the patient's condition and symptom severity. For men with moderate to severe lower urinary tract symptoms such as frequent urination, nighttime urination, or difficulty emptying the bladder, success rates are around 80–85%. Not everyone responds, and certain factors influence results. For example, Men with larger prostates and normal bladder function typically experience better outcomes. The challenge arises when the bladder becomes weakened over time, especially in older men who delay treatment. Once the bladder loses its strength, it's very difficult to restore normal function, which limits response rates. Prostate artery embolization also works well for other indications, such as treating blood in the urine, hematuria, where success rates are similarly around 85%. It's also effective for patients in acute urinary retention, who rely on catheters because they cannot urinate on their own. In these cases, we can successfully remove catheters in about 80% of patients. However, outcomes vary depending on how long the catheter has been in place. Those who've had one for years tend to have more bladder dysfunction, making recovery harder. Bladder dysfunction remains one of the biggest challenges for both embolization and transurethral procedures. Tests like urodynamics can help assess bladder function. In urodynamic testing, catheters are placed in the bladder and rectum to measure pressure while filling and voiding. This allows us to determine if the bladder is generating enough pressure to urinate properly. While helpful, the test is somewhat invasive, and interestingly, it's often more invasive than the embolization itself. Every medical procedure carries some risks, and prostate artery embolization is no exception. The most discussed risk is non-target embolization, where material inadvertently reaches areas other than the prostate, such as the penis, bladder, or rectum. Fortunately, this is rare and modern imaging minimizes the risk. Even when minor non-target embolization occurs, it usually resolves on its own without long-term issues. Severe complications like penile skin ulceration are extremely rare, less than 1%, and heal over time. Importantly, unlike other prostate procedures, embolization carries virtually no risk of erectile dysfunction, retrograde ejaculation, or loss of sexual function. Some men notice a slight decrease in ejaculatory volume afterward, which makes sense because embolization reduces prostate size and activity, similar to squeezing water out of a sponge. The prostate still exists, but becomes smaller and less engorged, leading to improved urinary flow and comfort. Since the prostate produces much of the seminal fluid, some reduction in ejaculate volume is expected, though most men report no noticeable difference. Traditional BPH treatments like Terpy, Urolift, or Resume can affect ejaculation and sometimes cause retrograde ejaculation, where semen flows backward into the bladder. Medications like tamsulosin can cause similar effects. In contrast, embolization has an exceedingly low risk of such side effects, practically near zero. Symptom relief typically begins around 2 weeks after the procedure, with full benefits becoming apparent within 6 weeks to several months as the prostate gradually shrinks. We usually reassess at 6 weeks to measure urinary flow and symptom improvement, and again at 6 months to evaluate prostate size reduction. For patients with catheters, we generally attempt removal 2 weeks post-procedure and try again 4 weeks later if necessary. Overall, prostate artery embolization is a safe, minimally invasive, and highly effective treatment option for BPH when performed by experienced specialists. It offers significant symptom relief, preserves sexual function, and provides lasting improvement in quality of life with very low complication rates.